Good morning, everyone. I'd like to call this meeting of the House Insurance Committee to order. The purpose of this meeting is to hear from experts on House Bill 1663, which provides for disclosures on how health insurers use artificial intelligence in reviewing claims and prior authorization requests. We will have a brief question and answer period after each presenter's testimony. Any comments, Madam Chair?
Just briefly, thank you, Madam Chair. Artificial intelligence has been in the national spotlight because of its applications in virtually all aspects of our lives. I do look forward to learning more about AI, how it's being used in the insurance and medical fields, and I do thank the panelists for appearing here today and for your testimony. Thank you.
Thank you. We also have the prime sponsor of House Bill 1663, Representative Venkat. Do you have any opening comments for us today?
Yeah. Thank you, Chair Kim and Chair Pickett, and to the Insurance Committee staff for convening this hearing. Obviously, I'm a health professional, and so take an interest in making sure that these new technologies are used in a beneficial way. What I'm looking forward to hearing from the experts before us is what type of regulatory framework, if any, we at the state level should be implementing to protect patients and our constituents while still allowing the efficient application of this technology in healthcare.
Thank you, Representative. We will be recording this meeting. We have a couple of representatives online. So if our testifiers could speak directly into the microphone, that would be very helpful. All right, our first testifier is Professor Oliver Goodenough, who is an AI expert with the Vermont Law and Graduate School. Professor Goodenough will be testifying virtually. Professor, thank you so much for joining us. Please start your testimony when ready.
Thank you so much. Thanks to Chair Kim and Chair Pickett and to the members of the committee for allowing me to provide some testimony. By way of brief introduction, I am affiliated, in addition to being an adjunct professor at Thayer School at Dartmouth and affiliated faculty at Stanford, in addition to being a research professor at Vermont Law School. I also am a director and officer of an early stage company that is applying some AI in various ways, but not in the insurance industry. And again, this testimony represents my own views and not views of many of my institutions that I'm affiliated with. I would like to touch on 3 or 4 points going forward. The first set of points really relating to what is AI, and excuse me if I get a little elemental in my starting point here. AI is the use of computers to do tasks that humans would otherwise perhaps do. And it has classically had 2 branches. One was a branch called rules-based AI, in which a program is set up with specific set rules of if this, then that kind of approach to the world. It's got certitude. It doesn't have flexibility unless the programmers have been very clever about building that in. The other branch is machine learning. And machine learning is a way in which we set up learning algorithms into the machine itself, which allows it to effectively learn from experience. The experience is provided typically by what's called training data, and that data then is used for the machine to over and over again iterate on finding similar answers to what the training data would do under similar circumstances. And so over time, that machine learning gets a probabilistic approach. Again, so the rules-based has certainty. This is probabilistic. It says, hey, with high probability, this kind of thing should go with this kind of thing. Machine learning has taken a big jump in the last few years, and it's particularly taken a big jump with the large language models, the LLMs, as they're sometimes called. The large language models effectively use training data and immense computing power to put together a network of probabilistic relationships between words. And if this word is here, then this word is likely to follow in this context, et cetera. So essentially, they are a machine that can construct good grammatical responses to a particularized prompt. The problem with them is that they haven't been optimized for truth or accuracy typically. They have been optimized to give this coherent response that we've all experienced it, how wonderful it is. They can write a poem, they can do that kind of thing. What they're not really good at is giving accurate responses, because that's not what they've been optimized for. Other AI techniques, other machine learning techniques can be optimized to give much more accurate answers. Again, it depends on how the machine how the machine learning algorithms are set up, what the training data is. There's a lot of variability in that. So we see applications are spreading in this. One of the concerns that comes up through these applications is what's called the black box concern. That essentially, because the machine has taught itself, it isn't always apparent what are the criteria that it is using to stick together. What does it learn to stick together? The probabilities of this followed by that. This is being to some degree ameliorated by the fact that folks are coming up with explainable AI, what's sometimes called XAI, and that explainability is increasing, but is not fully there yet. If we put it to use, given this probabilistic piece, and given the fact that we have to actually understand what it's been trained to do, good applications of AI frequently involve building in what are sometimes called guardrails. How do we check on it? How do we understand that it's been doing the right thing? Sometimes there's a second layer of AI which in effect checks certain kinds of aspects of it. Often there is what's sometimes called the human in the loop. We put a human in to check things as things go forward. So again, this black box, it can be a concern. It's not without its solutions, although none of those solutions are at this point perfect. Bias. There's a lot of concern that AI can sometimes deploy bias in its decision making. It's not an unfounded concern. Some of the earliest attempts, particularly in areas of law and justice, had bad bias built in. What is, I think, important to understand is there's nothing inherent in the machine learning process itself that is biased. It's an algorithm. It does what it does. Where that bias often comes from is actually from the training against human-produced data. And the machines are really quite good at, if there's already bias in the system, at saying, oh, that's how it works, and then applying the bias as well. So it is an important thing to be aware of. It is an important thing to take precautions against, but I think it's also important to remember there's nothing in these AI processes that are inherently themselves biased. They are really a byproduct of the human bias on which they've been trained and which they've learned too well to deploy. So against that background, how do we see this getting applied in insurance? Well, the work that I've been involved in insurance has often been on the rules side, because insurance is often about rules. An insurance bargain, a contract, is a set of policy, is a set of rules about if this happens, then you can qualify for this. The trick with that is spelling it out in code in a way that's useful, and then again applying it in a good way. Machine learning has been deployed to some degree to attempt to shortcut that long process of actually setting the firm rules and setting them into code. And instead, it's been turned loose on written policies to say, hey, here's the written policy, here's the request, how do they match up? What we've seen at any rate is that exercise is often not up to the standards of certitude that we would want to see in this. That said, those processes are being developed. People who have just thrown large language models at this are finding it difficult. Why? Because the large language models aren't optimized for making this decision. Much more specifically designed AI approaches, machine learning approaches, where you're really asking it not to optimize language, but rather say, based on this language, is this decision optimized? That kind of approach can have a much higher rate of success. Again, at some point in there, one wants to make sure there are the guardrails and the possibility of human in the loop and the things we've discussed. But there is the potential, I think, for significant time saving in evaluating claims and things in an insurance context. The trick is to make sure that that's being done well. As the introduction said, how can we find a way in which to achieve the savings and efficiencies that can come from this, while at the same time making sure that patients and other customers' rights are protected? The bill, if I could turn briefly to the bill is not necessarily, I think, fully there yet. And I had in my written testimony have some specific suggestions. One has to do with the definition of AI. I think it would be useful to clarify that definition to make sure that the rules-based approach, which has all kinds of different aspects and different capabilities, is not included in this bill, because it would be inappropriate, I think, to have the rules-based approach. The machine learning approach, I think, is what is there. I would just clarify that a little bit. I think that is already the intent of the legislation, but I'd clarify that. Secondly, on the transparency piece, it is important to make sure that these machine learning approaches are appropriately vetted, worked, etc. But I'm not sure that this approach is the right way to do it. I think it's flawed in 2 or 3 ways. First of all, I think it is too revealing. It is asking the companies to really, by saying, hey, what's your algorithm and what's your data set, essentially reveal the secret sauce of what they're up to in a way. I'm not sure that you're going to find the companies are eager for that, and having to do that might be an excessive drag on adoption, again, if we want adoption. On the other hand, it's also actually not very effective, because asking for the algorithm and the training set is really asking about, okay, how did you build the black box? It doesn't tell you what's in the black box. The better approach to figuring that out, from my standpoint, would be to develop a training set, a testing set, not a training set, a testing set of data, and say, hey, here's this data. What's your decision? Here's this data. What's your decision? And build into those tests concerns about the bias and other aspects we want to make sure the machine is producing. So I think, again, it's the wrong way around. And on the bias piece, rather than asking the department to be the certifier, it might, I think, be more effective and certainly less of a burden on the department to have the insurer effectively certify that it has taken care in its training set and has taken care about the bias piece, and then ask the department to test that rather than to certify it from the ground up. Also, I would say that as explainable AI, as XAI comes of age, you want to build into the bill, I think, some flexibility to permit the department to adopt additional or substitute measures, because the technology on how to test this stuff is just going to get better, and it's going to get better, I think, fairly rapidly as we go forward. In addition, I'm not sure that building the specialist into each decision is the right approach. Again, with sufficient guardrails, it might be better to build in the human in the loop at an appeals level. Say people can appeal, and any appeal would involve a human in the loop, rather than having a human check off each decision as it's made. Because again, if we're aiming to add efficiencies, hopefully some cost savings, hopefully things that benefit consumers as well as the companies, it will be, I think, important to allow those efficiencies to go forward. And if we've got a human second-guessing machine on every decision every time, I'm not sure that's going to be the best way. Again, human in the loop, important, but maybe in an appeals process. And lastly, in my suggestions, I was thinking that the levels of fines are high enough that it might discourage some potentially useful adoption. Perhaps some kind of differentiation between a reckless, willful, or knowing violation and an inadvertent violation might be useful in the penalty section. So those are my suggestions. That's my background. I'd be happy to answer questions. I refer you to my written testimony as well, which I hope will be helpful.
Thank you so much, Professor, for your testimony. We'll let you take a quick break. If we could have our members introduce themselves to the audience, I'd appreciate that. Let's start with Representative Zimmerman.
Yes, Representative Zimmerman, serving the 99th District, Northeast Lancaster County, and Southern Berks.
Teamwork makes the dream work, huh? Representative Nelson, Westmoreland County.
Representative Tina Pickett, Bradford and Wyoming counties.
Patty Kim, Dauphin and Cumberland counties.
Arvin Venkat, Allegheny County.
Representative Derecha Parker, Philadelphia County.
Representative Bob Mursky, Erie County.
I'm always embarrassed when Chairman Kim saves the best for last. Jim Haddock, Luzerne and Lackawanna County.
Thank you, Representative Favorite. So I'm going to start off with the professor with my question. Professor, again, thank you for your in-depth testimony. What I found intriguing was the how AI can deploy bias, and that nothing in the machine creates bias, but it's the human-produced data that puts it in the algorithm. Have you seen any ways that prevent this, I guess you call it a human in the loop? And what examples have you seen to prevent that if we get this started?
Well, the first piece is to understand the training data itself and try and filter that for bias, because again, the machine is the machine's like a kindergartner. You know, you teach it based on something, they learn that, they don't reflect upon it necessarily. So what the first step is to make sure that the training data isn't inherently biased in some ways. Classical human decision, what is often done is that the human decisions on this is then fed into the machine. Here's the info in this insurance thing. Here's what came in from the would-be patient. Here's the conclusion. Learn from that and try and replicate it over time. And you put in hundreds of thousands of those decisions, and it learns and it goes forward. If the humans making that disallowed everybody in Philadelphia, it would learn to disallow Philadelphia. They wouldn't learn the underlying rule-based approach that would be involved in that. So what we see then is the first step is to make sure the training data is as clear of that as possible. The second piece is to do what I was suggesting the department should do, which is then test it. Once it has learned, test it against the data and see against test data, and say test data has the things we're concerned about, whether it's gender, race, background. What are the invidious things that we would be concerned with, and then say, am I getting good results out of this machine or not? And again, that was the approach I was suggesting for the department, rather than going all the way back to the beginning piece and do it. And if it is showing that bias, then how do we correct for that? And do we have to throw the whole thing out, or can we correct? Can we put filters in that might help with that? The explainable AI folks are also able to back to some degree now to isolate out the factors behind decisions. In other words, work backwards through the process that we're and say, okay, test against this, test against this, test against this, and then identify the factors. So a good explainable AI can sometimes help you isolate factors, and if an invidious factor is part of that, we know we got a problem. There are techniques that are available for this. By the way, I also should mention that because the bias is coming out of humans, we should remember that the human systems are not free from this. I mean, sadly, we know that the human systems embed this. One of the reasons why we see it in the machine learning is because it's learned it from the humans. So we should be just aware that perfection may never be possible in any of this, but the reason that it's not is because humans are just as fallible, if not more so. So we should compare our machine to reality, and not to abstractions of perfection.
Thank you. Representative Eric Nelson has a question.
Thank you, Madam Chair. I'm looking at this TV in the opposite direction, so I'm not sure which way we go. I'll go this way. My question follows up in this area of bias. I've listened to discussions from medical professionals saying the opportunity to combine, biomarker testing in, let's say, the area of oncology, a patient's individual records, and then review that in a deep data dive across a lot of successful procedures to really pinpoint the best procedure that would be determined by this machine analysis to really be able to try to get the best care to the patient. In your experience, as you discuss bias and you're working with some of these medical models, is the treatment protocol driving the bias, or is it patient priority driving the bias? Because we have cost containment as well as necessarily opportunity for healing. In the models you work with now, which is getting the priority?
Well, Well, here's the again. I haven't directly experienced what you're talking about. I apologize. I have not directly experienced that. But working from first principles, there are two or three layers in your question. The first layer is what is being recommended if we use AI to do diagnostics and then make treatment recommendations. Um, we have to be sure that there is a broad enough population in the training subjects. One of the concerns is often that the training subjects come from white male upper middle class data, and that would leave out women, people of color, other potential targets. So one of the tricks is just to be sure that your training data is representative of the population you're making your decisions about, so that we are not making diagnostics against folks who aren't in the training set sufficiently to be properly represented. So that would be at the diagnostic level. That would be a level of concern. At the level of figuring out what is the efficiency versus the effectiveness, now we're talking about a different set of criteria. One of the criteria would be to what degree do we build that balance in? From a rules approach, you could have set weightings. If you've got a machine learning approach, sort of doing this, trying to emulate what other humans have done in this context, now again we're in a circumstance where human judgment is being used as the training data, and if that human judgment had bias in it, then that bias could appear. So again, test that data, test that approach against a test set of data, and really try and make sure that we've isolated out and things that we don't want in the mix. By the way, there's a famous study, a little controversial, of decision making by human judges, human parole officers, based actually in this case in Israel, where it turned out that one of the most telling factors about the length of incarceration and parole decisions was how close we were to lunch. Again, that's an example of a piece of irrelevancy into human decision making. If you'd trained an AI on that set, the first question would be, how close are we to lunch, before it looked at the benefits of the actual case. So again, it's that kind of thing that we want to make sure isn't contaminating the training data. I think the key element really is to look at how it's performing. Any one of these can be set up to be pretty good, and hopefully that's what a responsible insurance company would do, would set up something to be pretty good. But they need to test it. The department needs be in a position to test it, just to be sure that these more invidious elements aren't infecting the process. Actually, you'd want to do the same with a human. If you had a bunch of humans, you'd probably want to set up a review process where we keep track of the decision making of the humans. And if we had a bad examiner who ruled against everybody whose last name began with M, we'd want to catch that and throw it out as well. Again, it's not that these problems are necessarily inherent to AI, but they are inherent to trying to figure out how to make good decisions without extraneous elements coming in.
Thank you, Professor. We have two more questions, and then we need to move on to our next testifier. First, Representative Venkat, and then Representative Mirsky.
Thank you, Professor Goodenough. My question has to do with the enforcement mechanisms. You brought up having a testing data set that then allows, checking if bias is somehow in the training data set. So do such
or is somehow been expressed from the training data set into the AI process.
Right.
Yeah.
So the question I have is, are there validated testing data sets out there and tools out there? And can they be readily used by a state agency like our Department of Insurance that clearly does not have the technical expertise that is being employed in the insurance companies and frankly among healthcare providers and hospitals as well? And so what I'm trying to get at is this question of, can the foxes guard the hen house, so to speak? If the training data or if the testing data sets are not validated and are not easily used by an enforcement agency, then we are essentially saying we trust you, and that's not something we generally do in government.
I hear you on that one. I am not aware of a data set for what you are talking about. I think that it would be actually probably easier for the department to arrange a data set for testing than it would be for it to actually gain the expertise to actually evaluate the other end of the process, which is the combination of the algorithm and the data, the training data, which is what's currently in. I think this actually might be an interesting circumstance where interstate collaboration could be helpful. The folks at the National Association of Insurance Commissioners might be a locus for developing some of this kind of approach on a collaborative basis across a number of different departments. I hear you on the Pennsylvania department. I'm not sure that they have a background in this. There are folks who do, and I could actually put you in touch with some folks who are a bit more on this side. But again, I'm not aware of a specific set for what you're discussing. But its development would be, I think, a more tractable task than the actual alternative that's currently in the bill.
Thank you for your testimony today. And I just had one question. You know, we talked a lot about in terms of consumer protections and making sure that the system runs properly. But I did have a question on the back end in terms of, or the flip end, where we have insurance fraud. Would artificial intelligence, could bad actors manipulate the system for fraudulent activity? And just to speak on that a little bit, if you would.
And the answer is yes. They can manipulate the the human system as well. One of the things that is a possibility would be to build into this machine certain tags for fraud. Now, when you build in additional filters, you have to be concerned that some good claims may be filtered out, and you'd want to test for that as well. But one of the actually early applications that I've seen of machine learning was in fraud evaluation in a number of different things. There's several companies that have developed fraud evaluation pieces. Why? Because fraud often has its own characteristic and patterns. And once the machine learns the patterns of those fraud, then they can begin to watch out for it as well. Again, you'd want to make sure that there was an appeals button so that we could get to a human and for those cases that were being inappropriately filtered. But you can, in my experience, fraud is something that can be addressed in this, certainly as much as in a human, and perhaps rather more effectively. And before I leave the floor, I just want to mention that I was sorry not to hear anybody from Delaware County. I may live in Vermont now, but I grew up in Delaware County, and so I have a soft spot there.
Well, thank you very much, Professor, for your time and your insight. Thank you for joining us, and we hope you have a good rest of the day.
I appreciate it. Thank you. I may continue to attend with my camera and mic off just to hear more of the testimony, if I may.
Perfect, thank you. Our next testifier is Insurance Commissioner Michael Humphreys and Deputy Commissioner Shannon Logue. Whenever you're ready, Commissioner.
Thank you. Good morning, Chair Kim, Chair Pickett, members of the committee. Thank you for the opportunity to be here to discuss the use of AI in health insurance. As the chair mentioned, I'm joined by Shannon Logue, our Deputy Commissioner. Shannon oversees the office that reviews insurance company forms and rates, and is also served as my right hand in chairing the NAIC's Big Data and AI Working Group. And this morning, I'd like to actually focus on how AI in health insurance is being tackled at the national level, and then we'll bring it back down and talk about House Bill 1663. So I'll start with the work at the National Association of Insurance Commissioners. In 2023, the NAIC finalized a model bulletin on the use of AI by insurers. The process over a year plus included engagement with all stakeholders, consumer representatives, insurers, insurance producers, I think legislative organizations, watched, monitored, participated in conversations. In Pennsylvania, we issued a Pennsylvaniaized version of the model earlier this year. We also took a kind of public process where we vetted it, took comment, ultimately really aligned our approach with the national model for consistency purposes. To date, there's somewhere around 17 states that have enacted the NAIC bulletin in some form. Others have gone beyond that. The bulletin is not meant to be prescriptive in any way. Its goal was really to make insurers aware of regulators' expectations regarding how AI systems and practices will be governed and managed. We expect the insurers to use the technology in a way that's both ethical and fair. The bulletin confirms that AI's use should be done in compliance with existing federal and state laws and regulations. So the bulletin really sets forth expectations on the information and documentation that we expect an insurer to be able to produce upon our request, be it through exam or otherwise, and talks about best practices for using AI systems. And it really reiterates that our existing state laws around unfair trade practices, fraud, others, continue to be applicable in the use of AI. The department understands AI plays a critical role in the industry, and we cannot ignore its expansive reach. Several other states, as I mentioned, are incorporating NAIC's recommendations into their regulatory or statutory frameworks. New York and Colorado generally come to mind as kind of leaders in this space. In July of this year, New York adopted a circular letter, effectively their version of like a bulletin or a not quite reg, but has the force of law regarding the use of AI. And in 2021, Colorado enacted legislation prohibiting insurers from using external consumer data and information sources, algorithms, and predictive modeling that could unfairly discriminate against an individual. Colorado is continuing to work through its rulemaking processes, but under the Colorado law, the company must submit attestations from the chief risk officer that certify that the company has implemented its risk management framework to the department. As chair of the NAIC's Big Data and AI Working Group, we're committed to working through our efforts to understand and promote effective regulation of the use of big data and in the insurance industry. We're really in the, I would say, information gathering stage at this point in AI. We've conducted research analyzing state, federal, and international developments and regulation in the field of AI. And we're going to kind of bring back our learnings as well as what we're going to be doing for the next couple of months to develop policy recommendations for consideration by our parent committee, which is the NAIC's Innovation, Cybersecurity, and Technology Committee. Pertaining to health insurance, over the next 6 months, the working group will be surveying the use of AI in health insurance. We're currently piloting a survey. It's available on the NAIC website that we expect to go live later this fall with results coming in probably by the spring meeting. So I would say the March-April timeframe is when we'll have a chance to kind of go through the data, clean the data, and publicly report on how health insurers are using AI today. The survey that you can see online is one that we have probably, 6 to 10 companies that are confidentially working on just looking at the survey, making sure that we're asking the questions in the right way. I wanted to publicly expose that survey for any other comments that we would get from any interested party. So not a public comment period per se, but in the interest in full transparency, I put the survey out, I put it on the website, and we have had some comments come in, and I think we have made some adjustments to the survey as a result of those comments. But right now we're targeting, I think, to go live in November with the survey that will give companies probably 4-ish weeks to complete. And then as with any data survey that we issue, there's a cleaning period that comes after that. So hence kind of the delay into the early spring by the time we'll have, I think, good data publicly available. Now, we have done this already across the life, auto insurance, and homeowners insurance industries to identify how those companies are using AI. Each time we've had between 150 to 200 insurers respond to the surveys. To date, the results have shown that the property and casualty insurers have adopted the use of AI, I think, most often. Over half of property casualty insurers are using AI in claims, marketing, underwriting. I think we mentioned earlier fraud detection, risk management and fraud detection, while about a third of life insurance companies are using AI in marketing and underwriting. So our survey will now give us an opportunity to look at how it's being used currently in the health insurance space. And we are talking as a working group about kind of the follow-up surveys and how we continue to look at the industries that have already been surveyed to kind of continue our exploration of the use. And in some of those cases, the surveys are now 2 or 3 years old. So maintaining kind of accurate information of how companies and industries are using AI is kind of one of the top priorities that we have at the working group level. So circling back to House Bill 1663, we appreciate the introduction and being able to have this conversation today because we think it's an important one. There's several areas of the bill that we think are key to any comprehensive scheme to regulate AI, including transparency surrounding any AI-based processes used by insurers, including documentation of an insurer's internal processes, and also safeguards to ensure that any AI-based algorithms minimize the risk of bias. And that's another focus of where we're planning to go at the working group level, is to explore not only the role of third parties in the AI process, but the testing. And kind of there was a good discussion earlier about kind of testing data, but also kind of verification of testing, inputs versus outputs. All of that will be part of the conversation that we continue to have at the national level through the Big Data Working Group. Because we do believe that any statutory initiative should provide us with specific guidelines and tools, including staff expertise, to effectively monitor the use of AI standards. We plan to continue to navigate the ever-changing regulatory landscape, both here in Pennsylvania and nationally, as we continue that work to try to strike an appropriate balance between encouraging innovation while maintaining our strong consumer protections of the regulatory system that we regulate today. So again, I'd like to thank you for having us participate in this panel. Appreciate the introduction of the bill to be able to start this conversation. We certainly welcome any questions and dialogue today and following the hearing. So thank you, Madam Chairs.
Thank you, Commissioner. My question to you is, last year there was a ProPublica article that detailed the review of health insurance claims by Cigna, where a computer system was tasked with reviewing medical necessity. According to the article, this led to batches of claims being denied with little human oversight. Is the department aware of this tactic used by insurers, and does the NAIC's model bulletin address this practice?
We are aware of the article, and without getting too far into any investigation, whether or not one may have happened, would suggest to you that I think there was some misunderstanding in the article on AI versus a computer-generated system. What Cigna had was not artificial intelligence in the program. I mean, it was a designated program that looked at claims. Cigna has since changed its system as it has moved forward kind of in the claims development and claims review process. The NAIC model speaks broadly to the use of AI. So it doesn't necessarily get into the use of other systems that other regulatory tools already exist within our toolbox to be able to handle as state insurance departments.
Thank you. And then you had mentioned watching other industries like auto insurers. Broadly speaking, do consumers know that AI is used in some of their whatever procedures?
I'd say short answer is no. I think the longer answer is neither do we as insurance departments necessarily, and I don't think this is an insurance-specific issue either on the use of AI that we see kind of expanding throughout industries, whether it's healthcare, whether it's insurance, whether it's banking, and in other places. But that is why we are pulling together the survey at the NAIC level, is to really, I think before we develop what a framework for how you regulate it looks like. We really have to have the better understanding of how it's being used today, where it's being used today. So as we build kind of parameters and recommendations at the NAIC level that then we will take to you as individual insurance departments, to our oversight bodies at the legislature and otherwise, we have a comprehensive understanding of use and risk in the market today as it exists.
Thank you, and thank you for being so proactive in this space. Representative Venkat, do you have a question?
Thank you, Commissioner Humphreys. I really appreciate your testimony. My question is, clearly this technology is being deployed right now, and it's rapidly expanding. And we heard from the previous testifier that, at least right now, there isn't a validated testing algorithm or data set to judge bias or other things that we've already legislated against. So my question is, do we need a state-level legislative framework on this technology that would allow you to then regulate its application for the insurers under your auspices? Or is it enough that we say the insurers are certifying that they're meeting the criteria under the existing bulletin that you've already issued? I'm not interested in putting forward legislation if everything is hunky-dory, but I am very skeptical that it is hunky-dory because we're essentially relying on insurance companies, not that I think that they're purposely doing anything, where we have a black box process. We aren't really looking at these training data sets. We don't have a validated testing data set. You're expected to regulate against bias, and yet we don't have a framework for doing so beyond your saying you need to somehow regulate it. So is this necessary or not?
Yeah, really appreciate the question, and I don't think this should come to as a surprise to anyone sitting behind me, but I guess you can gauge by their eyes. But I don't think there should be an expectation that the NAIC bulletin is the end-all of where we will go with AI and reviewing AI. I think the idea is that that was the first step. Well, actually the second step, because there was a principles document that even preceded the document, the bulletin around AI. But the bulletin really came out to remind insurers and our regulated licensees that the existing protections against discrimination exist and apply to whatever technology you bring forward, whether it's AI, whether it's machine learning, whether it's human-based programs that you may employ, or even paper-based programs. The existing state regulatory system, I think, works and effectively provides an opportunity for departments to intervene where there could be opportunities for discrimination, for bias. I think that the second piece of the question is we're going to continue to go down that space and look at what testing looks like. In the bulletin itself, it was that companies using this, I mean, you should be having internal mechanisms where you are looking at the potential outcomes of the AI systems. You should be able to measure how it's impacting your populations of insured versus kind of the population at large, to be able to identify opportunities for bias. I think that, and where we continue to go with the third parties that they use to do it, and the programs and others that I think will exist to help test for bias and ultimately will help us examine in the future how programs are developed and impact the population, is where that next step will start to look. So I think I think answered your question is yes to both. I think the bulletin is a great first start. It tells the companies where we are. It gives them parameters for where they should be today, and also makes them aware that I think we're continuing to look at the issue and expect kind of collaboration into the future on where we go. And I think you will see over the next couple of years more guidance, more development of a more comprehensive framework for more holistically how AI should be governed into the future. I think one piece that I would say that's particularly to the health insurance space, and I think we've all had this conversation before in the context of insurance mandates. The slice of the pie that PID is responsible for is very small. I regulate probably 20% of the health insurance that's written in Pennsylvania. I mean, the bulk is, it's federal through Medicare. It's self-funded and governed by the federal government through DOL, through ERISA. It's Medicaid. So, I mean, there is also that intersection in kind of the federal role. And I think earlier this week, it may have been yesterday, you heard CMS talk about looking at developing stakeholder groups to look at technology and AI. Recently, you've heard, I think it was conversations about guidance in the drug development process and how you can use AI in that process. So it's a conversation that is happening here, it's happening nationally, it's happening federally, and it's one that even in introducing our survey, I made the CMS team aware that this is where we're going because they've expressed an interest to us in kind of continuing to monitor and working with states on how we address kind of health insurance more holistically. One of the first comments by one of the companies in the pilot group is a desire for consistency. And like they'll tell us, well, our rules, our programs may be different in different states as they develop different programs. It may be different for our federal block versus our state block. So I think there's that broader issue also of kind of the different market segments and where those regulators are, that kind of coming up with a framework will be our next challenge, and I think the next process that we endeavor on.
Thank you very much, Commissioner. We appreciate your testimony and time today.
You're welcome.
We have no further questions.
Do I go back to my seat? Thank you, Madam Chair.
Our next testifier is Michael Yanis, Vice President of Government Affairs for Highmark. Begin your testimony when ready. Mr. Yantis, thank you.
Good morning. I understand the committee is going to be pressed for time, so I'm going to waive off on reading the testimony. You folks have that. What I'd like to do is just call out what I think are the critical components for the committee to be aware of, and it'll add a little bit of different and additional information to what I think you've heard so far. And as Chair Pickett said, Mike Yantis with Highmark. Highmark is part of Highmark Health, which is a blended healthcare system. We have a 13-hospital health system out in Western PA. We have unique relationships in Central Pennsylvania. We're also in New York, West Virginia, and Delaware. And we look at this issue as a healthcare issue, not just a health insurance issue, not just a healthcare delivery issue, but a healthcare issue. So we deploy artificial intelligence across the enterprise with a focus on improving outcomes for our patients. But what's more important than what we use it for or how we use it is the governance model that we have in place that governs and oversees to make sure that we are using artificial intelligence responsibly and in an ethical manner. So our governance structure is based upon the principles of transparency, stewardship, and accountability, and it has 3 pillars that govern how we use artificial intelligence. We have a governance pillar, which is the process that we use to monitor risk and compliance with existing state laws, federal laws, et cetera. We have a policy pillar, and that is the pillar that establishes the guide rails for which and for how the enterprise is to use artificial intelligence in a responsible and ethical manner. And we have a cultural pillar, which is a distributed ownership and accountability pillar. So that is what focuses on people like me who are the employees across the enterprise and our use of artificial intelligence in our day-to-day jobs. Now, a couple of quick examples as to how we use artificial intelligence across the enterprise. We use artificial intelligence to analyze claims-based risk scores with the goal and measure to improve the outcomes for all of our members, our patients, and our customers. We also use predictive models that use machine learning to enhance assistance to our members that churn within our Medicare Advantage program. We also use generative AI that assists in the day-to-day operations of what we do. Spoiler alert, the testimony that we prepared, we actually used artificial intelligence to help prepare that because the testimony that is in front of you was a culmination of experts from across the enterprise. So folks from compliance, legal, data and analytics all provided us with information to support the testimony, and we used AI to organize that, and then our team would write and prepare the testimony. So a very basic example, but a day-to-day operation of how artificial intelligence helps streamline the way we do things across the enterprise. We also use ambient learning capabilities to assist in documenting our clinical interactions with folks. So that's on the healthcare delivery side. So I will say, it is more than just a health insurance issue. It is a healthcare issue, and I think the principles that we talked about need to be applied across the healthcare industry in order to ensure responsible and ethical use of artificial intelligence in that industry. I'll stop there, entertain any questions. I'm sorry that was kind of a rapid fire, but I wanted to be respectful to the time of the committee.
Yeah. Thank you, Mr. Yantis. My question is, I appreciate the governance model that you outlined. My question is, who's checking that it's working out from the outside?
From the outside, would that be our regulators?
So I guess the follow-up is, we just heard from at least the state level regulator to say their regulation at this point is a bulletin to you to say, follow existing state law. You have an internal structure that you believe is following state law. Right now, my understanding is that unless there is a complaint to the insurance department saying artificial intelligence was used and somehow it violated our existing framework, the state regulator would not know to check at this point. And I don't know that a consumer or a provider, or for that matter, somebody else, would know that AI was used in a particular process. So now we get into this circular loop was, people don't know it's being used on a particular decision-making process. You're presumably, and I believe this, trying to do what's right for your subscribers within the enterprise, but the outside regulator doesn't know or is not empowered under statute to check. So that's where we come in, obviously, as legislators. And I'm wondering if you have a comment or response to that.
Yeah, it's a great, I think it's a great way to frame the big picture issue on this. And I think that framework applies to almost, well, not almost, I think that framework applies to anything and everything that we do on the health insurance side as well as the healthcare delivery side. I think as equally as important as the outside checks and balances on that are the internal checks and balances that we have internally to make sure that we are complying with those external laws, because it has to be a balance. And there has to be a level of internal accountability, which we take very seriously, again, on both the insurance and the healthcare delivery side, to make sure that we are using it in a responsible and ethical manner. Same way that we make sure that we use the internet in that same way. You know, the same way that we make sure that we use any tools that are used for the betterment of our members in that manner, that is in compliance with state and federal laws.
Thank you for being here today and testifying. We appreciate your time. Our next testifier is Jonathan Greer, who is the president of the Insurance Federation of Pennsylvania. Jonathan, please begin when you're ready.
Good morning. My name is Jonathan Greer, and I am President and CEO of the Insurance Federation of Pennsylvania, a multi-line state trade association that includes commercial health insurers as its members. On behalf of our members, thank you for the opportunity to speak before you today on House Bill 1663, which seeks to regulate the use of artificial intelligence, AI, in health insurance. Before we speak to the issue of AI in health insurance and the bill itself, it's important to address, I think, the impetus behind this legislation in the first place. And Representative Venkat, your co-sponsorship memo from August of last year spoke directly, I'm glad Representative Chair Kim brought this up, spoke directly to the allegation made against Cigna, which is an IFP member company, about its purported use of AI and the denial of about 300,000 claims. Just to clear the record, that review program was no longer is, I think Commissioner Humphrey spoke accurately of this. It was called PXDX, and it was put in place to verify procedure codes submitted by providers. The application of PXDX to these codes applied after care was rendered and was intended to expedite reimbursement to providers. There was no use of AI or algorithms in this process, and since, excuse me, since it was applied to post-code claims, patient care was never impeded because of PXDX. Having said that, AI, as we've heard this morning, is rapidly becoming the cornerstone of innovation across numerous industries, and the insurance sector is no exception. On balance, we think that's a good thing, since if used responsibly, AI has the potential to solve complex problems more efficiently and improve the healthcare system for everyone. Specifically, AI has the current capability to reduce administrative burdens, facilitate disease prediction, personalize care, and reduce fraud. Recognizing the concerns the bill attempts to address, it's equally important to focus on how health insurers are not using AI. AI does not make coverage decisions. Coverage is based on the criteria and terms of member plans as well as clinical guidelines. AI does not issue clinical determinations and never replaces a healthcare provider's decision, including in the prior authorization process. Rather, it provides insights and information based on the latest medical knowledge, patient history, and historical outcomes. With respect to prior authorization, House Bill 1663 requires health insurers to notify veritably everyone, providers, policyholders, and the general public, on the use, non-use, or future use of AI-based algorithms in the UR or prior authorization process. The bill further requires insurers to submit their respective AI algorithms to the insurance department to determine these algorithms have minimized the risk of bias based on an individual's personal characteristics. This concern, as we've heard so far this morning, has already been addressed by the insurance department through its adoption of the NAIC's model bulletin in April of this year. We've heard a lot about that. I don't want to get into too much of my testimony, but it is important to say that that bulletin was partly based on principles that were adopted by the NAIC in 2020. And as the Commissioner said, there are 16 or 17 states that have adopted it. I think Pennsylvania was an early adopter of it. But it is spreading, and we regard that as something that states should seek to do on their own as they see fit. Different states may address it differently. The NAIC's continuing work in this area, which includes Commissioner Humphreys, as he spoke to, also speaks to its national scope. To that end, we think any legislation in this area should be part of a national, uniform, risk-based framework that adopts nationally accepted terminology as developed by the National Institute for Science and Technology, as well as the National Artificial Intelligence Initiative of 2020. Doing so will avoid a messy patchwork effect of state regulation. We also think, and this is important, any discussion on the future of AI warrants a broader discussion beyond health insurers. While AI remains in its embryonic state, media reports, including one in the July 10th edition of the New York Times, note it's already being used by providers as part of the appeals process. Separate media reports also indicate trial lawyers are now using it to streamline the time-consuming stages of litigation, particularly in the area of class action suits. We raise this not to deflect attention, but to rather point out the breadth of industries that have been or will be affected by the application of this technology, and why this topic is best suited for a holistic conversation at the national level. Thank you again for the opportunity to speak on this fascinating topic, and I welcome any questions.
So, Mr. Greer, thank you for your testimony. First of all, I'll state for the record, I agree with you. I think that the criticism that this needs to be regulated on a larger level beyond just the insurance industry and go to the issue of use in healthcare in general, as Mr. Yantis pointed out, is probably the approach that needs to be taken. So my question, I guess, is similar to the one I had to Mr. Yantis, which is, right now there is an insurance department bulletin, which is basically saying follow existing law. And yet we heard from the commissioner to say, well, this is an initial step. We don't necessarily have an enforcement mechanism behind it. And we've heard testimony that's saying that we're really in the Wild West when it comes to this issue of who's testing whether these approaches are actually meeting the standards that we presumably have already set. So my question is, do you believe that there is any state legislative role in regulating this, and we've seen that in other states, or is the position of the Insurance Federation that this should be solely a federal matter?
Well, let me first address the bulletin itself. It does a good bit more than say follow existing law. It tells us, it says you should have internal governance procedures in place to mitigate the chances of unanticipated bias. And I think that the commissioner spoke to this previously, and the concern I heard you express was, well, what are we doing on the front end? We only learn about this on the back end. What do we? I think the commissioner said appropriately that their expectations are outlined in that bulletin. And if for any reason, whether through an exam or any other procedure, the department examines an insurer, they're going to make sure that those expectations are being met. And part of that is that internal governance procedure to guard against, the chance of bias. I don't think anyone's intending to do that, but there's the unintended chance of that occurring, and there are controls in that notice that speak to governance to try to avoid that from happening. In terms of your question as to the scope of the issue, yeah, I think it's a national issue. I think it is an international issue. I think that states, frankly, this is not the role of the states. and I'm a state guy. But this issue is too big. And it's too rapidly evolving. And frankly, Congress is struggling with it. I think the EU is struggling with it. I think that somehow to think that Pennsylvania could do something that the rest of the world would follow, maybe, but I think that this is probably something that's going to really warrant a much broader discussion beyond this building.
I wanted to piggyback on what you just said, that this is happening at a rapid pace. Bill Gates was in an interview for a documentary and said, like, in the next 10 years, things would just be so dramatically different. I agree that we need a uniform set of rules, laws at the national level, but how important do you think, as we try to keep up with this pace, to speak with lawmakers as things progress? You say that you don't use AI for coverage, diagnostic tests, whatnot. I see that in the future. How important is it to communicate with us as things progress quickly?
Well, and that's partly the role also of the NAIC. When we speak to the national conversation, this is a national issue. This is an international issue. So to the extent to which the NAIC, which has done some good work in this space and continues to work, as the technology changes, so too will the reaction to it. And I think the NAIC, as it relates to insurance, definitely has a vital role to play as it relates to the national discussion and as it filters down to the states. Where does the future take us? I wish I knew. I don't have any idea. I'm not going to sit here we're kind of where the internet was in 1994. And no one knew in 2024 what the internet would become. We have no idea what the next 10 years, but it is rapidly evolving. And I think that it has great potential, both good and bad. It can be used as an incredible tool, but if not harnessed correctly, they're used responsibly. And that's really our focus. I think that's the NAIC's focus as well.
I think this is a great exercise for us to discuss this publicly. Thank you for your time. I don't see any other questions. I appreciate your testimony. All right, we'll now hear from a panel of healthcare providers, including Dr. Hal Banker, Senior Vice President, Chief Digital and Chief Information Officer for WellSpan Health, Casey Paulus, Senior VP for WellSpan Health, and Dr. Ritu Khurana, Geisinger Community Medical Center. Panelists, as you get settled, you can start whenever you're ready. Dr. Banker. Is your mic on?
Thank you.
All right.
Chair Kim and Chair Pickett and the members of the committee for having us here today. I'm Dr. Hal Baker, MD, and Senior Vice President of Chief Digital Information Officer for WellSpan Health. And I'm happy to be here to talk to you today about how AI is already improving healthcare in our communities. I'm glad to be joined today by Casey Paulus, who's Senior Vice President and Chief Nursing Executive for WellSpan. And with me, we try to manage the AI efforts of our health system. At WellSpan, we think the possibilities for AI are truly spectacular and numerous. It's the marriage of the human experience with the power of the technology, and it's allowing us to have a more high-touch, high-caring care situation that increases the speed and efficiency and improves quality and safety, and we want to share examples of those with you. But most exciting for us, it's returning joy and purpose to our healthcare delivery people, and that has been truly rewarding. Before I share those examples, it's important to note that we are implementing these solutions responsibly, always with patient privacy and protection in mind. We're among 28 health systems that joined an initiative under the U.S. Department of Health and Human Services Office of the National Coordinator for Health IT. And in that, we committed to AI solutions to optimize healthcare delivery and payment by expanding access, making healthcare more affordable, improving outcomes, improving patient experience, advancing health equity, and reducing clinician burnout, which is a problem. We committed to the FAVES principles: fair, appropriate, valid, effective, and safe outcomes. And as part of our effort, we inform users anytime a purely AI-generated output is coming in contact with them. And at WellSpan, for any diagnostic or treatment use, we ensure a human always has the final say. Computers and technology add infinite value, but they can't replace human empathy, expertise, judgment, and we believe that trust is of utmost importance as we leverage AI to provide cutting-edge care to our patients in our communities. We're careful how and when we share healthcare data for training, making a case-by-case determination, and we remain continuously conscious of the risk for bias slipping in to the training algorithm. At WellSpan, we are seeing very significant positive results, and we want to share 3 powerful examples of those. The first is Artisight, an ever-vigilant AI platform that identifies when a patient is moving in bed into a fall risk before a human can even notice that, but then can alert a human who can persuade the patient to wait for help. A pilot program at WellSpan Surgery and Rehabilitation Hospital has demonstrated a 52% reduction in falls, a 19% increase in patient experience scores, and 86% of our nurses report the virtual program greatly improved patient safety on the unit. And perhaps most importantly, to quote one of our nurses, returned joy to why I am in nursing. The technology is being used throughout WellSpan, and it's really going to change how we provide care. A second example is the use of AI to speed the accuracy and turnaround of studies. Our pioneers in this area have been our radiologist, using a product called ADOC. And this solution reviews the images from our CT scans immediately and highlights, prioritizes, and escalates abnormal findings for review and validation by the radiologist. It says which study should be read first when an AI abnormality is found, and thus ensuring more timely care to those who have positive findings. In some instances, up to 81% faster than with our old wait in line process. This allows us to identify the best next step for a patient who truly needs a next step. We've performed 152,000 studies in 1 year with ADOC and identified 8,000 positive cases for quicker care. Not only does it help our radiologists read with higher accuracy and speed, it also allows us to offer better access for our community as our diagnostic services perform 20% above industry benchmark. For my last example, how many of you have been to a healthcare visit and the provider seems to be focusing more on the computer than on you? To address this issue, we've implemented Dragon Ambient Experience, which uses an AI on top of voice recognition to draft a note of the encounter. It can tell who the patient is, who the doctor is, and who the family member is. And it does this in a way that often requires virtually no editing. Our clinicians, including myself, have been using DAX for several years, and the results are profound. Enhanced patient experience, increased efficiency for busy doctors, and reduced burnout. Many of our team have called it a game changer. We're literally turning the chair around and moving attention from the computer and the screen back to the patient where it always belonged. When used appropriately, AI enables physicians, nurses, and clinicians to optimize the patient-physician relationship. Time with patients, recovering, honestly, our professional mission and why we went into healthcare in the first place. That's going to be helpful as we face a worker shortage and resource scarcity. Finally, as this committee and the General Assembly consider options for legislative and regulatory frameworks, we have a few ideas to share. First is that regulations in AI need to be flexible and keep up with the incredibly rapid pace of innovation and allow hospitals and clinicians to safely harness the benefits for the good of their patients. There is a balance between fully realizing the promise of AI while managing the risk of deploying these really powerful technologies. As such, it is important to think of risk as a sliding scale and not an absolute, and how human oversight needs to be given to every application. Technology is most effectively regulated based on how and where it is used, and this sector-specific approach would allow you to tailor specifics of regulations to the risks associated with the use of that technology in that sector. AI is not monolithic, and thus a one-size-fits-all approach could inadvertently stifle innovation in patient care and hospital operations, and such an approach may even prove inadequate in addressing the risk and safety and privacy that are unique to healthcare. Just as software regulated based on its use across different softwares, we encourage you to consider regulating AI in a similar way. Thank you again for the opportunity to share our testimony today, and we at WellSpan stand ready to serve as a trusted partner to the committee and the General Assembly in any way we can as we navigate how AI is to be used to improve lives, health, and outcomes for the patients we serve.
Thank you. Dr. Kurata, please.
Will give a little bit different perspective as a physician, working physician. I also have a master's in legal studies from Thomas Klein Law School. So I do talk a lot about the legal and ethical issues of AI in different, areas in the country and around the country. So I read through the bill and I saw a lot of issues, and I'll give you real-time examples why I think that this could be a problem in the future. I am all about AI. We know it's here. We cannot deny it. If we don't go with it, we're going to be left behind. But there are a lot of patients. That's the difference I feel. Everybody's talked about the legal issues, the bias, the visibility. Nobody is talking about how a human, that's why we are doctors. I feel like we treat every individual patient differently. So putting them into a computer algorithm and figuring out stuff, I'll give you an example. I had a 40-year-old woman the other day who has a history of lupus, came in with chest pain. She went to the emergency room, was diagnosed with GERD, and she got a PPI and was sent home. She called me the next day. She said, so I have this intermittent chest pain. It comes when I walk up and down the steps to do my housework. Now, we all know that as physicians and as a rheumatologist, the most common cause of death in lupus is an MI. But because this is where an AI bias would come, because it's a 40-year-old female, we wouldn't think females get MIs, and so her stress test wasn't approved. And I had to actually pick up the phone, call someone, get her approved for a stress test, and she's getting it tomorrow, but we don't know. So I don't know the company who refused it had AI in the system or not, but I have this, you're putting these biases in there that coronary artery disease is more common in young men, it doesn't happen in young females, but it doesn't put the other comorbid conditions. Another example, and I can only give you rheumatology examples, but I had a young man, 36-year-old, who had a history of cardiomyopathy and rheumatoid arthritis. So we sent and we put him on oral methotrexate and DMARDs and stuff. And I know these are medicines that you probably don't use, but I'm telling you, we put in a medicine for him called Orencia for a prior authorization to treat his rheumatoid arthritis. And the answer we got, again, I don't know it was AI generated, but I have a big fear when we have AI, these people are going to be lumped into it. And the answer was this medication is denied because the formulary with the insurance company is an anti-TNF, like an Enbrel or a Humira, use that. Now, it did not take into account that young guy had cardiomyopathy with an ejection fraction of 20% of his heart, and the Enbrel and Humira were contraindicated in him. So again, we had to pick up the phone, call somebody, explain this, which trust me, you never get a human there either when you're trying to appeal all these. But these are some examples of real life where, I feel there should always be mandatory. When there are denials, somebody should look into it and not just say, oh, this treatment is denied, this test is denied, this is denied. That is the biggest fear with healthcare providers today. I spoke to Geisinger, it's a big health system, and now it was bought by Kaiser, but I spoke to the leaders up there before I came here, and this is what everybody's fear is that they wanted me to represent here is once we have AI in the systems without any human, again, human in the loop or human supervision, we are just gonna, and then there are patients who are vulnerable, and this is where disparity comes. Elderly patients, not so educated patients who don't know how to use the appeals process or go online and do all this, they will just, oh, this medicine's denied, and this is the second best, and this is what my insurance is paying for, let me get this. But they don't know how to navigate through the appeals process to get their medicine approved, or they don't understand that, although the physicians do help with that. But sometimes they just don't understand, and they just don't get substandard care with that. So those are some things that I wanted to say about that. Again, another issue was accountability and transparency with insurance companies. We never get a reason for those denials. They go, oh, this medicine is denied. You can choose this, this, or this instead. There are a lot of, generic is the wrong word, but there are a lot of biosimilars, and I know you might be aware that the first medicines were Enbrel and Humira, but we have much cheaper alternatives now for them. And a patient who's been on that drug and doing well is now being asked to go with a biosimilar, and we don't have a problem. But once I applied for a prior authorization for a Humira, for a patient who'd been on it for 11 years for rheumatoid arthritis, and the insurance company said, oh, this medicine's denied, pick another alternative. And we just didn't know what was formulary, so we picked an alternative of Humira as Usimre. That took another 15 days to get an answer. Oh, this is also not on formulary, pick another drug. So after a month, we literally had to call and say, what is your formulary? Tell us, and we will pick that drug. And they don't have an answer. So it's just like a hidden trial. You keep writing, get this drug. Oh, this is denied. There's no transparency why they're denying the drug. I'm a big believer. I do a lot of AI in my personal space, in my office space, but I just think without human involvement, AI is only going to give out what we tell it to give out. The Watson oncology data is the biggest failure of AI. When it came in the early 90s to early 2000s, it was the biggest thing in the world. But then after 12 months, they figured out it was giving all wrong treatment algorithms because there were no patients that they tested. It was a bunch of oncologists who said, oh, I treat it like this, and I treat lung cancer like this, and I treat lung cancer like this. And they put their own opinions into that, and they just kept using the same data to treat further patients. And 12 months later, they didn't disclose for 12 months that that wasn't working. And 12 months later, oh, well, this is the wrong data, and we're not going to use it anymore. So it's just that those examples, specific examples that as a physician, I am worried that where we are going with AI, it's just, we're going to need a human in there to look over this. Thank you.
Thank you for your testimonies. Representative Venkat, do you have a question?
Yeah, so I appreciate the examples, and Dr. Khurana, you're reminding me of my clinical situation, so I understood those terms that you put out there. But I guess the question for the panel is, and I'll borrow from what Mr. Greer said, there is this article out there from the New York Times that talks about health professionals and hospitals now using artificial intelligence almost in an arms race to get around, prior authorization denials, utilization reviews, downcoding, whatever the case may be. And that worries me now, putting on my legislator's hat, because this escalating arms race is likely to be at the cost of the patient, our constituents, related to the cost of insurance, utilization, all these things that factor in. So it again goes back to this question that I've had for every panelist. Do we need a state-level legislative framework to put guardrails around this in the healthcare setting in addition to the insurance setting?
Thank you for that question. We would advocate for a flexible solution, and I think that's the key message we want everyone to hear. We think, as we think about healthcare, our job, our responsibility is to ensure safe healthcare. That's our number one priority, and so we support whatever is going to allow us to continue to be flexible and evolve and continue to provide safe care. The examples we gave, we believe, are supporting us in increasing how we can provide safe care to patients. And so we would just be big proponents of making sure any legislature is going to be flexible enough to allow us to continue to evolve and meet the needs of patients in the future, especially knowing we're going to continue to face really incredible staffing challenges on the forefront as we think of caring for a largely aging population. and those people leaving the workforce, we have a lot of challenges in front of us, and so we need to make sure we have room to be creative in the solutions we deploy that are still providing high-quality, safe care.
I actually think that at the state level, we should definitely have something. I know I heard this is a much bigger problem, and we should have a federal and a national law, but I think our patients and our insurance companies are state-specific, and we should have these human guardrails with transparency and bias, and when they start using AI for these purposes, we should have them follow state laws about, how they use AI, and always make sure that it's not a generic answer that they output. I think it is important at a state level because our insurances are very state-specific too.
Thank you very much. I really liked, Alia, did you pick our panelists? We have someone that says, great balance, we can help prevent falls, and then Dr. Khurana is saying we need to be very, very careful. We have taken all of your feedback and taken copious notes so that we can have them when we think of future laws in the future. So we thank you so much for your time and your feedback. It was really important. We are going to end with that. Thank you. We have a comment from Madam Chair.
Thank you. Are we at the end of our meeting, Madam Chair? Okay, well, I thank all of you too, everyone who came to testify for us today and be part of this meeting today. I want to thank our staff on both sides of the aisle for their hard work. They do a great job for everything that we do. I do appreciate the majority of this committee keeping us well informed of the committee planning and inviting our Republican staff to meetings on legislation. And I thank you, Madam Chair, for taking the helm in the middle of the session. It's been a pleasure working with you. I wish you well in your next adventure.
Thank you, Madam Chair. It's been an honor, and I will be missing everybody. Maybe I'll see you on the other side, but thank you again for your time, and thank you, Representative Venkat, for prompting this hearing. Appreciate it.
Thank you so much for having us and listening to us. Thank you. It does matter when you all want to listen to physicians' concerns. Thank you.
Absolutely. You're welcome. And this meeting is adjourned.